hospital bills and insurance, which believe me, is very complicated. In general, when you go see your doctor, basically whatever it may be, but let's just say you have a curvature of your penis and it hurts, it's been there, you go see your doctor. Well, when you go see your doctor, the clinic have to have a person that does prior authorization. And what that person's going to do is she actually has to run your insurance to know, A, are you in network with this physician? B, if you are in network, what is your co-deductible? And so that's why when you show up to your doctor's office, sometimes you may pay zero, sometimes you may pay $5, sometimes you may pay $30. So it all depends on your plan. Once you go there and you pay your co-deductible, then you go see your doctor. Then when your doctor sees you, your surgeon is gonna do a physical exam, history, the usual. Let's say that you have a curvature to the right that's 40 degrees. In theory, anyways, is due to repeated trauma causing calcium deposition at a specific area on the shaft of the penis. And that calcium is not flexible like the corpora. And so what's going to happen is it's going to cause the penis to curve. So your surgeon's going to explain, the risk, benefit, whatnot, answer all your questions and all that. And then let's say you're like, okay, doctor, I'd like to proceed with the surgery. Then from there, the doctor has to write a note with what is the diagnosis and basically justify to the insurance why you need that surgery.
Priceless, take it to the moon. Priceless, one day will be soon. What is priceless?
Hi everyone, welcome to another episode of D-Talk with Dr. Pham. So, I have people message me to ask certain topics that I can talk about. And one of them is hospital bills and insurance, which, believe me, is very complicated. I own a billing company, and so I know we bill for other surgeons. But in general, when you go see your doctor, basically whatever it may be, I'm just going to use an example like a kidney stone or a penile surgery. And I'll cover penile diseases with other episodes because there's just so much. But let's just say you have a curvature of your penis and it hurts, it's been there, you go see your doctor. Well, when you go see your doctor, the clinic have to have a person that does prior authorization. And what that person's going to do is she actually has to run your insurance to know, A, are you in network with this physician? B, if you are in network, what is your co-deductible? And so that's why when you show up to your doctor's office, sometimes you may pay zero, sometimes you may pay $5, sometimes you may pay $30. So it all depends on your plan. With the exception of Medicaid, there is no co-insurance. They just that's one of the benefit of Medicaid is for surgeons or doctors that take Medicaid, and it's becoming less and less just because of the reimbursement. And usually that's up to the practice. They run their financial numbers and then they decide, is it worth it or not? But we're not going to go into that today. But once you go there and, you pay your co-deductible, then you go see your doctor. Then when your doctor sees you, your surgeon is going to, do a physical exam, history, the usual. And basically what he's going to do is he's going to examine you, and let's say that you have a curvature to the right that's 40 degrees that needs to be corrected because of pain with erections or pain with intercourse, whatever it may be. So then he would write a note. Well, before he writes a note, he's going to explain to the patient, okay, this is what you have. Like I said, we're just going to use an example. So he'll tell the patient, this is what you have. What you have is Peyronie's disease. And that's caused by, in theory anyways, is due to repeated trauma causing calcium deposition at a specific area on the shaft of the penis. And that calcium is not flexible like the corpora. And so what's going to happen is it's going to cause the penis to curve. So your surgeon's going to explain, the risk, benefit, whatnot, answer all your questions and all that. And then let's say you're like, okay, doctor, I'd like to proceed with the surgery. Then from there, the doctor has to write a note with what is the diagnosis and basically justify to the insurance why you need that surgery. And that's something called prior authorization. Then, depending on the insurance, the prior authorization person or department, depending on how big your practice is, but would reach out to, let's say, Blue Cross Blue Shield and would basically try to get prior authorization, meaning authorization to perform that surgery. And usually the code is not typically it's not one code, meaning that your surgeon is not just having to, just go in there and cut out the plaque, right? So what he has to do is he has to cut out the plaque and then use some sort of graft to fill in the defect. In this case, it will be pseudoplast, which is a cavitaric pericardium. And so basically, but he also needs to do, he may need to rotate your skin around because now that the penis is fixed, then, instead of a curved penis like that, this is a concave, right? So he'll make an incision here. Then what he's going to do is when he fills in the graft, you're not going to have enough skin right here. So then he's going to need to, or he or she your surgeon will need to actually use skin and rotate it around. And that's what we call rotation of local skin flap. And then if there's any other stuff, then, he would get authorization for all that. So that's why in the clinic, the doctor or your surgeon gives you kind of the big picture. But from an insurance standpoint, he has to list out everything that he's requesting to do, which I think is a good idea because it's better to request it and your insurance say yes and you don't end up needing to do it than the other way around, which is you're under anesthesia already. You find something that you didn't notice in the office because you couldn't see it. Then what's going to happen is your surgeon has to retro bill it. And so when you retro bill it, then now it can become a little tricky because you know how insurance are. They may say, no, we didn't approve that part of the surgery. So let's say now that your surgeon has examined you, then he's going to now has to put in his notes basically the reason why you're here and what surgery he intends to perform and the rationale for doing that surgery. Keep in mind, these surgeries are expensive. I don't know the costs. Obviously, I'm just a plumber, but basically, I don't know the cost is the bottom line. All I know is how do I fix this? And so let's say that your surgeon has diagnosed you and, your penis is curved like this and he goes over the options with you on different treatment. And let's say that you and your surgeon decide that surgery is the best route to go. So then from there, your surgeon actually will need to write a note in his medical record, in your medical record, the EMR, to show why you came, what symptom is it causing you, what is the risk and benefit of doing the surgery, and why you and your surgeon decided to go with surgery instead of some alternative route, if there's an alternative route. And so then from there, he will there's something called a CPT code, which is basically a surgical code or a procedure code in the surgery world. And then you also have something called an ICD 10 code. So, what an ICD 10 code is, it's a code that basically lets the insurance know what your surgeon actually diagnosed you with. Then he's going to put the CPT codes that will correspond with the ICD 10 codes, which will sh- basically show all the procedure that he's going to perform, right? Rarely is there a procedure where you only do one thing, especially with penile surgery. I know I've done probably over 14,000 cases, penile cases, so I know. And basically, when your surgeon explains to you about the surgery in the clinic, most surgeons are not gonna go into like, oh, okay, I'm gonna be doing this. This is the CPT for rotating the skin is 14040. That's like that just wastes his time and it'll just confuse the patient more. All he's gonna do is explain to you exactly what he's gonna do, but from an insurance standpoint, he can't just say, this is what I'm going to do. He basically has to list out what he's going to do and, you know, the just think of it as the language. The language between the surgeon and the insurance is going to be your ICD 10 code. So then that's what the insurance will use to determine whether prior authorization is required or not. And what I mean by that is this: there are some procedures that is just straightforward. There's no really issues with or evidence against doing that surgery. Like that, like surgery is usually the route to go. So with those, when the prior authorization person sends up the authorization to request the insurance to pay for that surgery, if it's a code that the insurance already know, like it's pointless to do a peer to peer and all that, then they would just approve it. Now, one caveat is there are procedures that don't really have a code. And that's probably, I have to say, in my experience, anyways, less than 1%. Then you have to use something called an unlisted code. So then the insurance will always approve the unlisted code because what they're going to do is when it comes time to reimbursement, they generally will look at what you did and was it a justified portion of the surgery. So I don't like uncertainty, and so I don't like to use unlisted codes unless there's just really no other codes. Um, because there's going to be a lot of back and forth between the surgeon and the office. I'm sorry, the surgeon and the insurance company on why it was justified or why it wasn't justified. So for me, I always like to list out codes that actually has a procedure affiliated with it. And thank goodness for what I do and what my partners do. Like I said, probably less than 1% are what we call where there's no CPT codes for it. Usually in Crescent Urology Institute's experience, unlisted codes typically occur when we're called in for intraoperative consults because some of the stuff that we do, there is no code for it. And a perfect example is fixing the bladder laparoscopically or robotically. There's a code to fix the bladder if an incision was made. So, meaning that there's a CPT code that corresponds with fixing the bladder if there was an incision. So, like, if they actually got into the bladder during a C section, for instance, then that's easy. However, let's say that a surgeon's doing some sort of laparoscopic surgery, let's just say laparoscopic hysterectomy or robotic hysterectomy, and the surgeon got into the bladder. Well, there's no code that is specific for fixing the bladder robotically or laparoscopically. And so that's where it becomes tricky. So you just have to send off the charges as an unlisted code, and then the insurance will then look at the operative report and look at why we were called intraoperatively. And generally speaking, they're pretty fair. They'll look at it and they're like, you know what, uh, you know, we'll pay for it because the bladder was injured. It doesn't make sense for us, and we're not going to ever let financials stand in the way of patient care. So my partners and I, we're all trained in robotic surgery, laparoscopic surgery, open surgery, and endoscopic surgery. So we're not going to make an incision to fix the bladder just so that there's a code that we know we're going to get paid. That's not what we're about. My philosophy has always been patient care first. We'll deal with everything later. And generally, the insurance they're reasonable. So what they'll do is they'll look at the op report and they'll be like, okay, so basically there was a bladder injury, but it was done laparoscopically because of the hysterectomy. These guys came in since the patient didn't have an incision, then they just fixed it laparoscopically. Versus if let's say they're doing the laparoscopic hysterectomy and then the ureter was injured, then there's a code for that. So then we fix it laparoscopically or robotically. The reimbursement is the same, whether you do it robotically or laparoscopically. And I'll talk about laparoscopy, open surgery, robotic surgery, endoscopic surgery on another episode, just so that patients can understand what the risk and benefit of each type of surgery. So the old saying, right? There's more than one way to skin the cat, and so it just depends on surgeon preference and all that. So basically, that's what the CPT code and the ICD-10 and that. So just that alone should help you on the day of surgery, because on the day of surgery, on the consent, you're going to have all these other things that were listed that you're going to be like, wait, my surgeon never talked to me about it. And a perfect example would be, we can go back to that Peyronie's disease. So, the patient may also have, when we tell them we're going to use skin to cover the defect, because keep in mind with Peyronie's, once it's curved, and to make it straight, I would need to cut right here and then put a graft in there. Well, when I do that, this concave area is going to be longer, and then this convex area is going to be shorter, right? And so now I have to kind of move skin around locally to cover it. And so that's called rotational local skin flap. And then let's say that there's some issue with the scrotum also, then that's called a scrotoplasty. So a lot of patients sometimes, well, I wouldn't say a lot because I'm pretty thorough with my patients, but in general, if on the day of your surgery, if the consent has all these foreign words, that's what they're referring to, is because the insurance and the hospital, and for legal purposes, you really should list out everything that you are going to do, so that patients fully understand exactly what needs to be done. In my case, I don't have a lot of that, and that's why my clinic, unfortunately, always kind of run a little bit behind, because for patients that have seen me, they know my philosophy has always been questions should be asked during the consultation, not the day of surgery. The day of surgery, the patient should know exactly what's going to be done, and risk and benefit and all of that. The day of surgery really is just more for like any last minute question that is non urgent. And I think in my 15 years, I've only canceled one case where I felt the parents just really didn't fully understand everything that was going on, even though it was a simple surgery. And initially, the parents were upset because they kept saying they understood. But then when I asked them specific questions, they really didn't understand. And so I canceled the surgery because I wanted parents to really come back to see me in the clinic so that I can kind of re-explain all this. And in the end, the patient actually sent me a card and a gift, um, that basically, just say thank you because they felt much more comfortable when surgery was performed the second time. Well, there was no surgery performed the first time because I canceled it. So if I ever feel like a patient fully just don't fully know exactly everything I'm going to do, I will cancel the surgery. And so that's why I take time um, to really explain all this. I'm not a revolving door surgeon, and if you ask any surgeon, and I don't really do circumcisions. And that the reason why is I talk about circumcision in the third episode. And so if you watch that episode, you'll understand why I really don't do circumcision. All the surgeries I do are what you consider major. So either botch or something that's more complicated, not circumcisions. And so, but hopefully that helps you now understand why what your surgeon said the day in the clinic. Now, I'm referring to a surgeon who's thorough. Now, if you have a surgeon that's kind of 1 foot in the door, 1 foot out the door, well, I don't know what to tell you. Basically, maybe get a second opinion. I'm not sure, uh, but for me, I hope that kind of makes sense. At least on the diagnosis and the CPT codes, and why when you sign the consent, there's a lot of stuff written on there, but really it's just everything that your surgeon had told you in the clinic. It's just for consent purposes and insurance purposes. He or she has to list everything out so that the hospital gets paid, the surgeon gets paid, and the right deductible is calculated. Okay. And so now let's talk about the fees. So when you have surgery, rarely will you have a surgeon that hires his own anesthesiologist, has his own place where he takes patients to do surgery, and the have his own assistant and everything. That's if a surgeon does have that, I mean, more power to you. But generally speaking, I probably would say 99% of surgeons, that's not the case. So usually a surgeon will take a patient. So let's say this patient with the Peyronie's disease decide to move forward with the surgery. We got the authorization, the insurance requested the notes. They looked through everything and they're like, okay, approve. If they don't approve, then you can do something called an appeal process where the insurance will have doctors or nurses or whatnot. Typically, in my experience, I always, when I do a peer to peer, they always set me up with a surgeon or at least a doctor. And it may not, most of the time they're not even urologists, but it doesn't matter. They have enough knowledge to know what you're talking about. And usually the peer to peer process is really not them trying to not have the insurance pay for your surgery. They just need to get a little bit more information because from my understanding, after talking to, because I have friends that do that, from my understanding, what they tell me is that basically when you submit all these CPT codes, they just punch into a program. and then it doesn't look at the overall picture. And so it can flag one code like a circumcision. And so then automatically that will trigger a peer to peer. But once you actually talk to the physician on the other line and you explain, oh, the reason why I'm doing the circumcision is not because I want to do the circumcision, it's because I need the skin. And so the patient's going to end up with a circumcised look. And so that's why we requested the circumcision. Then at that point, yeah, usually I have to admit, they're all the ones I had to deal with, they're very fair and stuff. And once I explain to them, they're like, "Oh, okay, that makes sense." Basically, you're doing a circumcision because not because the patient just wanted a circumcision. You're doing it because you're fixing something bigger, and you need some of that foreskin. And without that foreskin, you won't be able to do your surgery. But with the foreskin, you will be able to correct the patient's pathology. And then, but there's not going to be enough skin for me to reconstruct the penile foreskin to look uncircumcised. Once in a blue moon, I may have a patient that has enough skin for me to do what I need to do to fix the main pathology and then still give them an uncircumcised look. But generally speaking, I maybe done that in the last 15 year, maybe twice. Most patients, because it takes longer for me to reconstruct the foreskin. Most patients or parents are like, "It's okay, Dr. Pham, do what you need to do. We trust you." So I never really run into that issue that much. And so, and then basically after surgery, depending on your type of surgery, there's also something called a global period. So what that means is that the fee that you pay within 90 days, if there's any issues that's related to the surgery itself, then you don't have to pay for the clinic visit or anything that has to do with uh, the surgery, with the exception of if the surgeon actually has to do another procedure. So what I mean by that, let's say you fix the curved penis, everything is good. Patient started to have cellulitis 4 weeks later. Well, he comes in to see you in the clinic, then you assess him and you tell him, okay, it looks like you have an infection. We're going to put you on some antibiotics. Well, then really you can't charge the patient for that clinic visit and the work that goes into examining the patient and sending in the medication and all that. However, if you come back to see the surgeon at 4 weeks because of cellulitis, however, there's also an abscess that now requires the surgeon to perform a procedure. Well, then that's not considered global because now then it's very nuanced, but that's now considered something that is affiliated with the surgery. However, it requires a procedure. And so with that, then global period doesn't apply in that situation. And it can get tricky, but typically if you have to perform a procedure, i.e. if this a patient with a Peyronie's disease end up having an abscess requiring that I have to take them to the operating room to basically open up the penis, drain the abscess, leave a drain, redo this, redo that, whatever it may be, then the insurance will pay as if um, it's a new thing. And it works the same way. We would then get authorization. We would explain to the patient, okay, um, the patient has an abscess, antibiotics, we've already tried antibiotics, or I don't think antibiotics going to work, whatever it may be. That's a conversation you have with your surgeon. And then that's why, it's important to discuss all this with your surgeon so that you can come up with a comprehensive plan. And so hopefully that kind of help explain about the surgeon's fee. Okay. Now there's also the facility fee. And like I mentioned before, not all surgeons have their own surgery center and all that. But regardless, it still works the same. Even if the surgeon owns his own surgery center, he the surgery center really acts as a different entity. And so there's a facility fee, which means the place to operate at. And so, the place to operate at, the sutures, the equipment, the whatever, and so that's a separate fee. And that fee will come from the facility. And that's pretty straightforward. Then now you also have the anesthesiology fee. So, the anesthesiologist, um, basically has their own fee that, they have to put you to sleep and all that. So you will get a bill from anesthesia. And typically hospitals don't employ their own physicians. Now I'm not a lawyer, but I think there's kind of rules to that where the hospital itself can't really employ their own anesthesiologist. But don't quote me on that. If you really want to know more about that, then let me know. I can bring a lawyer on, a healthcare lawyer that can answer that. But that's just my kind of general understanding. And so you'll get a bill from them for putting you to sleep. Then now you also have a surgical assistant fee. So not all physicians work with residents. Uh, for me, for example, I don't work with residents. Now I do train residents once a month, because they need someone to train them because they need 20 cases to graduate. So, I'm a clinical, assistant professor for the general surgery program at HCA Kingwood. And so once a month, I train residents so that they can get their cases so that they can graduate. And so, but generally speaking, just because of the type of surgery I do, basically patients come to see me to have me do it and not to have a resident train on their child. And so I we you know or I at least, my it's up my partners can do whatever they want, whoever they feel comfortable with. But just like Grey's Anatomy, how you have a surgeon operate on the other side of the table where, you know, they're retracting, keeping everything clean, making sure that the main surgeon can see what he's doing. Now, of course, it's not as dramatic as Grey's Anatomy. We don't have a lot of, oh my, 3 units of blood and all this. It's not, you don't see that in the OR. Is actually very boring. And so we just contract with a group that what they do is they will send down the surgical assistant, and they usually just charge the patient a flat price, because usually insurance don't have surgical assistants in their network, just because of, I'm assuming they pay low. And so what these surgical assistant groups do is they will bill the patients out of network. That's how they make their money. And so, but we strike a special deal where with this group called PTM Medical Solutions, where they actually will just charge a flat rate. And then depending on your insurance, you can actually get it reimbursed, because the surgeries I do typically are surgical assistance allowed or required, meaning that the the insurance recognized those codes that, without a surgical assistant, complication rates go up. And so, And then depending on your insurance, like I said, they will reimburse you the whole amount, half the amount, three-fourth the amount, none of the amount, whatever. Like I said, I don't really get involved with the billing side of that. So I don't know, but I don't really have patients kind of ask me about that. Usually, if they have questions, they'll call the billing department. But hopefully, everything I talked about today gives you a better understanding of when you undergo a surgery, there's multiple moving parts and there's multiple fees. And it's not just a one fee and then that's it. And so I think a lot of patients do get confused and frustrated because, I know the cost of healthcare is high, but it also depends on their plan and all that. But hopefully, what I explain kind of can help you better understand your bill and all that. And I'll leave with this. Typically, when they send you a form, like let's say you're Aetna, Blue Cross Blue Shield, whatever it may be, they'll show you like what the charges are and what the actual payment is. So don't pay too much attention to those charges. And I think that's where a lot of patients think that, the surgeon is getting paid like, oh my God, this outrageous amount. No, typically the rule of thumb is we always bill 3 times the rate of Medicare just so that we can get paid the contracted rate. Now, why? I absolutely have no idea. I have asked, and no one seems to know why that is. Like, basically, if you don't bill 3 times the rate of Medicare, then you're going to get paid less than what your contracted amount is. Now, that's what I was told by my director of billing. And so, so don't, kind of like the FBI, I can neither confirm or deny it. But when you look at the bill, you're going to see these huge numbers. Those numbers are not really what we get paid. What we get paid is whatever the managed care group insurance has already contracted with us. And so, but that's pretty much it for medical billing. So hopefully you find this helpful and it can help you next time when you have surgery. You'll understand now why you're getting multiple. If you like what I'm doing, you find it informational, please click on the link below, subscribe. And if there's a lot of interest in it, then I will continue doing this. But like I said, my goal of doing this really is purely to educate the public on kind of medicine in general, with a little bit of focus really on men's health in general. So future episodes, a lot of it will be dedicated to diseases and pathology that really afflicts men, but we do female also. And so, but it's just men in general don't really have a lot of areas or places they can turn to with kind of trusted knowledge, because nowadays everybody seems to be a Dr. Google or a Dr. Facebook, and not really, they kind of read bits and pieces here, and then it just confused them. So if you like it, please subscribe, and we'll go from there. This is Dr. Pham signing out.
We gon' do it like it's priceless. Take it to the moon. Priceless. One day will be soon. Like it's priceless.